Thank you, David. I'm honored to be the finale speaker today for what's really been a fantastic symposium. Congratulations to you for this wonderful time. It's been amazing to see all these people so passionate about this sad disease. So I'm honored to be here. I'm going to talk about quality of life after total pancreatectomy and auto islet transplant. So to illustrate the problem, I thought I'd tell you about a few of my patients. The first one is a 22-year-old college student who had intermittent bouts of pancreatitis since childhood. She'd had multiple ERCPs without durable relief. And then she developed evidence of chronic pancreatitis with a progressive course, daily pain, and then she found that she had to that she couldn't continue in her college classes. She had a single CFTR gene mutation. So she underwent total pancreatectomy with islet autotransplant. We harvested over 400,000 islets, and she's now pain-free, narcotic-free, insulin-free. She's back to school and playing volleyball. So obviously this is a grand success, and if all or even most of my patients were like this, or our patients were like this, then I wouldn't be up here talking, and so obviously that's not the case. A second patient, 43-year-old woman who's a veterinarian, also a runner, and had recurrent acute pancreatitis, had been labeled as sphincter Vodi dysfunction. She had undergone multiple ERCPs and an operative sphincteroplasty, and none of them with durable relief. And then she developed evidence of chronic pancreatitis, had daily pain, daily narcotic requirement, and wasn't able to eat consistently, and had to quit her job and was about to lose her practice. So she had a total pancreatectomy with islet autotransplant. We harvested over 200,000 islets, and she's now pain-free and narcotic-free, back to her veterinary practice. She actually ran the New York Marathon last November. But she uses an insulin pump to control her blood sugar and requires, on average, about 14 units a day. So, success or failure, I think both are, you can say, you can go either way with this, but obviously I think most of us think this is a success and that her islet failure is a different issue. And then a third patient, this one's a little more challenging. She's a 27-year-old woman with recurrent acute pancreatitis beginning at the age of 11. She had multiple hospitalizations, endoscopic interventions, and she had a Whipple in 2005. She did great after that surgery for about 4 years and actually went back to college and completed her undergraduate degree. And then she developed her pain again and was stuck in the hospital. We couldn't really get her home, had multiple long, 3-month-long admissions, and was taking over 2,000 oral morphine equivalents daily. So she underwent a total pancreatectomy with islet autotransplant with a harvest of almost 200,000 islets. And now she's over 3 years out. She's on 135 oral morphine equivalents a day. But she's out of the hospital and she's working on her law degree. Now she takes 14 units of insulin a day. So what about her? Is she a success or a failure? I mean, she'll tell you she thinks she's a resounding success, and we think so too. But how do you measure that? And that's the real problem. So defining outcomes in surgery for chronic pancreatitis is a real challenge. The pain mechanisms are really poorly understood, and patient expectation and physician expectation for surgery is really very different. And so it's an important question. I thought I'd look back historically at how people have measured outcomes in chronic pancreatitis surgery, and then talk a little bit about the timely concept of patient-centered outcomes, and then discuss the SF36 and SF12 and talk about some practical applications. So it seems fitting in considering the history of pancreas surgery to go back to Dr. Whipple's early description of extensive pancreatectomy for chronic pancreatitis. He presented his series of 5 patients back in 1946 to the American Surgical Society Association. And I found it clever in his introductory remarks that he made remarks that we may even hear today. Sounds very much like things that are said at meetings in the present time. He said, present-day adjuvants to the surgeon's armamentarium have made radical operations feasible, which 10 years ago were considered impossible. So this is an excerpt from his results table on his 5 patients that had extensive pancreatectomy. The first one, and these are the results that he described. So the first one was relieved of pain. Second one, relieved of all former pain. Third one, relieved of epigastric pain. Fourth one, entirely free from pain. And the fifth one died. But all of these are his description, the physician's description or the physician's assessment of the success of pain relief. And if you look at the ensuing 50-plus years of surgical reported outcomes in chronic pancreatitis, they really all have very similar metrics. So many of them, most of them, are the physician's assessment of the success of the pain relief. And then some of them do have patient surveys, but they're fairly crude or rudimentary, where they say that, they ask the patient if they're pain-free, are they better, or do they have no improvement from surgery, or they have crude pain scales. The notable exception to this, of course, is the group in Germany who really took a thoughtful approach to trying to describe objective results for pain relief after chronic pancreatitis surgery. And they developed their pain score that had 4 different components, looking at frequency of pain attacks, visual analog score, analgesic medication use, and the time of disease-related inability to work. And they also used the European Organization for the Research and Treatment of Cancer, the EORTC Quality of Life Survey. And these are wonderful measures. They use them consistently, and it was a good way to see their outcomes, but really this didn't catch on and really didn't ever make it over to the US. And so I think we can do better than this, obviously, with our chronic pancreatitis outcomes measurement. As Galileo said, measure what is measurable and make measurable what is not so. So the concept of patient-centered care is really pervasive in all talks about healthcare reform. It's a term we hear all the time, and I think a talk on outcomes measures would be remiss without mentioning it. Nothing about me without me has become the sort of battle cry of shared decision-making advocates. And several landmark references go back to the psychology literature. Engel proposed a biopsychosocial model of healthcare that would take into account the patient, the social context in which he lives, and the complementary system devised by society to deal with the disruptive effects of illness. And then Kleinman, also a psychologist, differentiated disease, which is the physician's concept of pathophysiology, from illness, which is the patient's subjective experience of feeling sick, and felt strongly about differentiating these. And these concepts, as you can see, sort of started in the 60s, 70s, and 80s, but really have gained traction over the past decade or so with the healthcare reform movement. And landmark Institute of Medicine report in 2001, Crossing the Quality Chasm, started talking about patient-centered care, and they call it the fundamental approach that's essential to improving U.S. healthcare quality. The Patient Protection and Affordable Care Act of 2010, also known as Obamacare, has really embraced this concept. There's a lot of concentration on developing the patient-centered medical home, which shifts the bias of healthcare towards the primary care doctor again in order to improve quality and to improve cost efficiency. And then the Affordable Care Act also created the Patient-Centered Outcomes Research Institute, or PCORI, which is charged with shifting the emphasis of patient outcomes research to the patient's perspective and looking at patient-reported outcomes. Patient-centered outcomes, the concept rests on the fact that numbers or traditional biomarkers like LDL or hemoglobin A1C alone, which in the past have driven treatment decisions for patients, that these are not the greatest markers perhaps, and that really the goal of healthcare administration should be improved patient function and well-being. And so measures of this, patient-reported health-related quality of life measures, are essential then to outcomes research in the modern healthcare. Now, there are a lot of quality of life measures out there. Many organizations have developed their own for their disease-specific purposes. But the one that's most commonly used and the one that we've adapted, and many of us have adapted, is the short-form health survey, the SF-36 and SF-12. So the short-form 36 was developed for use in the medical outcome study, which began in 1981 at the University of Chicago, and then was continued by the RAND Corporation and the New England Medical Center. And it incorporated information from 23,000 patients. It's a 36-item survey that looks at functional health and well-being on 8 domains. So there's general health, physical functioning, physical and emotional role limits, social functioning, mental health, vitality and energy, and bodily pain. And they bring these questions and domains into 2 component summary scores, the physical and mental component summary score, that are designed for common use. So the SF-36 is a great tool, mostly because it's validated. So it's been validated on many different levels and many different diseases and against other quality of life measures, and has good internal retest and retest reliability. It's also generic, which is appealing because it allows you to give context to a disease. So you can compare quality of life for chronic pancreatitis in reference to other diseases and across gender and age. It's pertinent. So, a lot of us are looking at the health-related quality of life. How does this disease affect our patient? And that's what this tool measures. It's also quick and easy to complete, so it's usable. And it's norm-based, so the scores are standardized to a healthy population. Now, they're standardized to a healthy U.S. population. And the last standardization happened in 2009, so it's relatively modern. The SF-12 is a survey that we've used, which is just a 12-item survey that's been derived from the SF-36. It's meant to be more efficient. It also looks at 8 domains of functional health and well-being without any loss of information with this efficiency, and it's been validated against the SF-36 in chronic pancreatitis. We began using it mostly because of convenience, as our behavioral psychologists had adapted it in our system. So the SF-12 and SF-36 are the most widely used patient-reported outcomes measures in the world. They've been administered over 38 million times. They're used by the Centers for Medicare and Medicaid Services, the National Committee for Quality Assurance, most major medical centers and healthcare systems, and pharmaceutical companies. So it's commonly used, which makes it even more useful. In Charleston, we have used the SF-36 and the SF-12 to evaluate our patients as they respond to total pancreatectomy with islet autotransplant. We switched from the SF-36 initially to the SF-12, mostly due to convenience, but you can coordinate those measures. The first thing we noticed when we looked at our patients preoperatively is that they were really a very miserable group. This slide shows the physical component score on the left and the mental health component score on the right of our patients. They're in orange. Again, the far right blue bar shows a healthy population that the scores have been normalized against. And so that's the mean of a normal healthy population. Our patients are shown in orange. In general, 1.5 standard deviations below the norm is considered at the clinically impaired range. So anyone, or a mean score below 35 is considered clinically impaired. And so clearly our patients preoperatively are pretty miserable. And this slide also compares it to patients on dialysis in yellow and patients with congestive heart failure in blue who look relatively happy. We looked initially at our first 33 patients and compared our patients preoperatively to their scores at 6 months after surgery and at 12 months after surgery. And we found pretty dramatically our patients very quickly, within 6 months, had these statistically significant improvements in their both physical and mental health quality of life. That was impressive. So they went from the clinically impaired range into the clinically well range. Interestingly, we also looked at our narcotic data, which was far less positive, and we found that at 6 months, only 25% of our patients were narcotic-free. But of the 75% still on narcotics, 85% of those had improved quality of life. So clearly it's a very different measure than just narcotic use, which is more complicated. We looked again at our numbers. That was our first 33 patients, and then we looked again last summer at our numbers and reported at the European Pancreas Club. And even with larger numbers, the quality of life improvements seem to stick. We've then applied quality of life as a measure in different subsets of patients. So we looked at patients that were reoperative patients that had failed prior pancreas surgery, and so these were our salvage pancreatectomy patients. And we thought that they often might be worse off in some ways, but we found that their quality of life, again, was miserable preoperatively, but they had a nice and similar improvement in their quality of life postoperatively to patients who hadn't had prior surgery. We also looked at our patients, we presented this yesterday, who had new insulin requirements or worse insulin requirements, and found that they too had similar improvements in quality of life to those who had more successful endocrine outcomes. And then we have other subsets of patients that we've looked at, and that we looked at those patients who who have had significant complications after surgery or who have failed to wean narcotics. And again, they have similar improvements in quality of life to those who do better. And then many of the groups that are represented here in the past couple days also have used quality of life outcomes as a measure in total pancreatectomy with islet autotransplant. Milena and the group at Minnesota looked at pediatric patients using SF36 back in 2011. Their group, Dr. Sutherland, their whole group looked at their entire experience, and they had data on 114 patients, again using SF12, and found improvements at 6 months. The group at Cleveland Clinic looked at 20 patients, and they used the Pain Disability Index instead of the SF36, but they found improvement at 12 months. John Christine and the UAB group looked at their 91 patients, again using the SF36, and he came to those conclusions about alcoholic pancreatitis maybe not being a great preoperative indication for surgery. And then lastly, the Cincinnati group reported on 20 pediatric patients, 7 of which they had SF36 data on that showed improvement at 9 months. So clearly, many of us have agreed or seem to have a consensus that quality of life is an important outcome measure, and that SF36 may be a reasonable tool to measure that. While this consensus seems to be there, there's still a lot of issues that need to be sorted out about SF36 and its interpretation, though. There's not been a true consistent definition of what a good outcome is and how you define that using the SF36. Is it a certain point improvement? So it's standardized, and the standard deviation of 10 makes each point different mean something between patients, but what's an improvement? Certainly a single point improvement can't matter, but maybe it's a 3-point improvement, maybe it's a 5-point improvement, and there have been different publications to advocate both those measures, but it's not clear. You can also look at patients that are so-called clinically impaired or have a score less than 35. If they move into the non-impaired range, does that make it a success? Or you can use standard statistical tests or other such measures to say that it's improved, but it's hard to know, and there's no consensus of what really defines a successful outcome. And then finally, the designers of the SF36 really advocate using the component summary scores, but they also have the subscores that matter too, and it's hard to know which of those are important and relevant and which ones we should concentrate on to define a good outcome. And then last, I wanted to speak about data collection. These survey data can be very cumbersome to keep track of as you develop more and more patients. And we've been fortunate to have some clever behavioral psychologists that work with us that have developed a very easy and useful way to collect this data. They've created something called the Element System, and it's an online computerized psychosocial triage and clinical outcomes tracking system. And all of our patients with pancreatitis, whether they're surgical or not, get assessed at their initial visit with us. And they get a battery of tests that includes the SF12, a depression scale, an opioid misuse measure, a brief pain inventory, and then our homegrown pancreatitis-specific questionnaire that asks about symptoms and hospital utilization, diabetes, and some nutritional stuff, and what medications they're using. And then at each subsequent visit, they do a portion of this. So they do the SF12 and our homegrown questionnaire. It takes about 20 minutes at the initial intake, and then it's only about 10 minutes after that for them to answer these questions. When they get put into a clinic room, rather than sitting and waiting, the nurse brings up the Element screen for them, and they go ahead and do the survey right there. For those that are afraid of the computer, the nurse will sit there and do it on paper and then put it in for them. But what this allows for us is it updates the data in real time. So I can sit back in my physician office before I go in, and along with looking at their vital signs, for example, or their weight, I can pull up their Element System data that they've just put in, and so I can be prepared for how they're doing. And so it's nice for me, it's like another vital sign in real time. But then I can also look back and I can follow their time, their progress over time longitudinally. And then we can use it for data to look at a group's progress or response to an intervention. So it's been very useful. So in conclusion, the patient-centered outcomes are an essential metric in the modern era of healthcare. Patient-reported quality of life is an important measure in outcomes research in chronic pancreatitis. The short-form measures are reasonable tools to measure quality of life. And consistency is going to be important to enable our collaboration between institutions and to facilitate the interpretation of everyone's outcomes. Thank you.